Good evening, everyone. Thank you for joining our neurology talk. Today we have Dr. Lin, who will be discussing approaches to movement disorders. And she's currently an IMT3 and an academic fellow in neurology in Sheffield. We can wait till about 7:05, and then we can make a start just while people are just joining. If you have any questions, you can put them in the chat and I can keep an eye on this. And then you can let me know if you want me to discuss them right at the end or during. Dr. Lin.
Hi, thank you so much. I think let's do it along the way because I'll be discussing multiple topics, so it might be easy for people to just ask me while I go rather than keeping it until the end. So I'm happy to be disrupted if needed, just to ask the questions. That should be okay.
Great, I'll do that.
All right, shall we make a start then?
Yes.
All right. Good evening, everyone. My name is Lin Tuleimat, and I'm one of the internal medicine trainees due to become a neurology registrar in a couple of months. And I'm also an academic clinical fellow in neurology at Sheffield Teaching Hospitals. And today we'll be going to discuss movement disorders, the most common ones, and how is a neurologist going to approach them. We're going to go through the differential diagnoses for them and then the evidence-based management for each of them. And as we said in the start, feel free to ask questions along the way, and I'll try to answer all of them as we go along because we will be discussing more than one movement disorder. It's easier for us to just go through it as we go in terms of questions. So we're going to make a start now. Just a second. Okay, this is not working. So again, just a minute. I don't know why it's not working. Yeah. Okay, so we're going to start off with the most common movement disorders that we see, which is Parkinson's disease, including idiopathic Parkinson's disease, as well as Parkinsonian plus syndromes. And basically, we want to go through understanding what's the underlying pathophysiologies of idiopathic Parkinson's disease as well as Parkinsonian plus syndromes, and then develop a proper clinical approach to both. And you'll find out with neurology generally and with movement disorder specifically that the diagnosis is all in the approach in terms of history and physical examination. And then we're gonna go through the up-to-date and the evidence-based workup and management of such syndromes and what's the prognosis that is expected for each of these subtypes. So Parkinson's disease is actually the second commonest neurodegenerative disease, and that is exceeded only by Alzheimer's, which is the most prevalent. And it's estimated that around 1 in 37 people that are alive today in the UK will be diagnosed with Parkinson's disease in their lifetime. And the recent estimates has showed that at around 150,000 people live with Parkinson's disease in the UK. The last was done in 2020. And there is around the world, around 5 million people who are suffering from this disorder. And usually the mean age of onset is usually 60 years old, but we have seen patients as young as 20 years old and sometimes even younger. But we find that the frequency of Parkinson does increase with aging. Now, why it's important to know about all of this? Because as you can see, it is a very prevalent disease. It has a lot of healthcare implications, financial implications, on the patients, their families, and their healthcare. So that's why we need to understand it, and we need to know how to diagnose it, and what are the up-to-date treatments that we can help people lead a better quality of life, not have a large amount of morbidity or mortality or burden in different aspects, as I just said. Now, pathologically, the hallmark feature of Parkinson's disease, as you all may know, is degeneration of the dopaminergic neurons in the substantia nigra, and therefore there will be reduced striatal dopamine. Now, and that also includes intracytoplasmic proteinaceous inclusions, which are known as Lewy body, that we can see on biopsy for these patients. There is a neuronal degeneration with an inclusion body formation, which is the Lewy body, and that we not only see in the substantia nigra, but also in cholinergic neurons, like the nucleus basalis of Maynard, the norepinephrine neurons in the locus coeruleus, and serotonin neurons in the raphe nuclei of the brainstem, as well as the neurons of the olfactory system and the cerebral hemispheres, spinal cord, peripheral autonomic nervous system. And that's what you actually see in terms of symptoms that patients present with, is that many of these domains and what they actually help the function with will be affected in Parkinson's disease. Like, for example, the olfactory system, it being affected, people usually have problems with hyponosmia or early on in their diseases, and that's actually the earliest sign of Parkinson's disease. So all of these areas that are affected, you can see that effect in their symptoms that they present with. Now, a typical Parkinsonism, on the other hand, it refers to a group of neurodegenerative conditions, and these are usually having more widespread degeneration than we find in the idiopathic Parkinson's disease. And that involves usually an alpha-synuclein pathology as well as tauopathy. And they usually present with Parkinsonian features. However, they have a slightly different clinical picture than Parkinson's, and that is dependent on the underlying pathology and it being more widespread and having specific misfolded proteins like synucleinopathy and tauopathy. Now, to understand Parkinson's pathophysiology better and risk factors, basically there has been epidemiological studies that previously suggested that there is an increased risk to Parkinson's with exposure to pesticides, people who are in rural living, if they're drinking well water. So these were pointed to be possible risk factors for patients developing Parkinson. On the other hand, they observed that cigarette smoking and caffeine can actually reduce risk. However, no environmental factor has been determined to cause PD. It's more of an associative relationship rather than a causative, because it's only in epidemiological studies. So it's difficult to be able to assess whether it's causative, but it showed that there is that kind of relationship, which is associative. Now, having said that, this is something that you went through in terms of how it causes the bradykinesia in medical school, but this is just to go through it again in more detail. We know that the substantia nigra will be denervated. That leads to dopamine denervation. That by itself can lead to increased firing of the neurons in the subthalamic nuclei as well as globus pallidus interna. And that, because of the increased firing, it causes inhibition of the thalamus, which again causes reduced activation of the cortical motor systems, and therefore we will have bradykinesia and slowness of movement and all the presenting symptoms that we're going to go through in the next 5 to 10 minutes. But essentially, it's the denervation increases the firing in the subthalamic nucleus of globus pallidus, which causes inhibition in the thalamus. That by itself causes decreased movement, in short. And basically, the current role for surgery or things or procedures like deep brain stimulation has been based upon this model because there was a prediction that lesions or high-frequency stimulation of regions such as the subthalamic nuclei or the globus pallidus interna might actually reduce this neuronal overactivity and therefore reduce that slowness because of the inhibition of the thalamus. This is just for your own understanding as well of what causes Parkinson's disease in associative manner and what happens on a cellular level. So as we discussed, there will be protein aggregation and inclusion bodies like Lewy bodies. And then in Parkinsonian plus syndrome, there will be tauopathy and alpha-synucleinopathy. All of these were abnormal protein aggregation, which causes oxidative stress, and oxidative stress in turn actually causes more protein aggregation. So it's kind of a ongoing relationship between both, and they both feed each other. Mitochondrial dysfunction, which has many reasons, but it contributes to protein aggregation and vice versa. Obviously, mitochondrial dysfunction tends to happen more often as people age, but things like lifestyle can majorly impact the mitochondrial function. So a healthy lifestyle where there is an increased level of exercise and movement and minimal processed foods can actually help the mitochondrial function maintain a lot longer. And therefore, that actually just reduces the possibility of having other chronic diseases, which overall maintains the mitochondrial function fairly intact. Obviously, inflammation is another factor. And again, protein aggregation does induce inflammation. And with more inflammation, we get more protein aggregation. As you can see, this is all affecting on a cyclical basis. So protein aggregation is the center of all of this, but all of these feed into it and vice versa. And additional inflammation in the body can actually make this more likely. And excitotoxicity, as you can see, because of the dopamine, which is not present as much anymore, there is an increased firing in the subthalamic nuclei and the globus pallidus interna. So that causes excitotoxicity, which is what causes the lack of mobility or decreased mobility. So it's important to just take it as a full picture that way and understand fully why do we get that development of these symptoms. by understanding that there are more than one pathway involved in causing the pathology that we see under the microscope for Parkinson's disease, we're able to understand the full picture of it and why do people present with various symptoms, specifically with Parkinson's plus syndrome. It also helps us try to create more studies. There are many, many studies that are happening now that are looking at things like the microbiome and how it can actually impact all of these aspects. And that helps us in the future to hopefully prevent movement disorders like Parkinson's disease, which decreases its burden and morbidity and mortality. And there has been many studies about the microbiome and how it can connect early on. The constituents of the microbiome can make it more likely to have Parkinson's disease specifically and neurodegeneration in general, because there is always that contact between the GI, specifically through the vagus nerve, and the central nervous system and vice versa. So they always feed each other. So whatever goes on in the gastrointestinal system can have a high impact on what goes on in the brain, which now there has been many studies which are, we're still in the early stages, but it does show that this has a significant impact on the protein aggregation and the protein pathology that we see in neurodegeneration generally. And this is a very active area of research, which hopefully can lead us one day to actually prevent Parkinson's disease. Now, this is just to show you what we see when we do a post-mortem examination for patients with Parkinson or biopsies. So the first two pictures just showed you a normal brainstem and substantia nigra versus an atrophied one that is denervated from dopaminergic neurons. And then here you can see the Lewy bodies and the inclusion bodies here, which is pointed here. And then you can see here the difference between the picture on the left and then the picture on the right. The picture on the left is normal, and the one on the right actually shows that there is a denervation and there is less number of dopaminergic cells. Now, this is what we went through about the Parkinson's disease pathology. In dyskinesia, unfortunately, because that happens with more advancement of the disease, where they actually become more kinetic or hyperkinetic, but abnormally. And that is because the dopamine is present in the system, which actually has the opposite effect of what we just discussed and what happens with PD. So it actually, there is more firing from the thalamus, which means because there is more dopamine, so there is more firing from the thalamus, which means there will be more abnormal movements that are occurring. And this we see in later stages of the disease, rather than initially. And it can be quite difficult to treat. Now, having discussed the pathophysiology and the etiologies and the risk factors to this disease, what are the clinical features that we can see for Parkinson's disease? There are 4 cardinal features that we all are aware of, which is the bradykinesia, the rest tremor, the rigidity, and the postural instability when they mobilize. But there are other motor features and non-motor features that can also be diagnostic and can be the first presenting features, so it's important to be aware of them. So things like mycographia, where their handwriting becomes much, much smaller than their usual, that is a very early sign. And masked faces, or what we call hypomemia. And basically, you'll see that they're barely making any facial expressions. They will have a reduced eye blink, and you'll find that their voice becomes a lot softer and very, very low in terms of the pitchness and its volume, and that's what we call hypophonia. They might have some issues with swallowing to solids or liquids and have dysphagia, and they will have freezing of gait where it's very difficult for them to initiate the movement, and this is what we call freezing. There's also non-motor features that are as equally important, and there might be present sometimes 10 to 20 years before the diagnosis and might be the only symptom at that point. So things like anosmia, as we discussed, and sensory disturbances such as pain in the limbs could be also a sign. They might develop mood disorders such as depression and anxiety. And they can also develop sleep disturbances, the most common of which is REM sleep disorders, so the rapid eye movement sleep disorders. And again, this is something that could be present up to 20 years before the diagnosis itself. So this is something to consider when taking the history. Autonomic disturbances, which tend to occur later in the disease, but very important to be aware of them, to know how to treat them promptly and early. So things like orthostatic hypotension, gastrointestinal disturbances, genitourinary disturbances, and sexual dysfunction. These are all important bits that could occur later in the disease and important to treat. Specifically the orthostatic hypotension, because it can impact their mobility further because of how dizzy they feel. So it's important to target it with the appropriate management accordingly. And then cognitive impairment and dementia, it could occur not in all patients. So this is not something that definitely will ensue later in the disease. Some patients are more likely to get dementia related to Parkinson. And there is Lewy body dementia, and the difference is just between the onset of the cognitive impairment, where it's later in the disease, in Parkinson's disease dementia, while in Lewy body dementia, this is actually the presenting feature earlier than all the other motor features. But not everyone who has Parkinson's disease will go on to develop dementia. Some people will have just very mild cognitive impairment. Now, the other subsets of Parkinson's, which is Parkinsonian plus syndrome, the first one is multiple system atrophy, and it's just important to know the headlines of the symptoms that they could present that could differentiate them from idiopathic Parkinson's disease. The most important part for you to know is autonomic dysfunction, as we discussed, the most important of which is orthostatic hypotension. And then urogenital dysfunction, along with the Parkinsonian features that we have discussed. And there's a subset of patients who will have cerebellar dysfunction, which could present as ataxia, limb ataxia, or ataxic dysarthria. And basically, based on that, we have either a possible we have two categories of multiple system atrophy, either one that's Parkinsonian dominated or cerebellar dominated. And as the name suggests, the Parkinsonian one will have more Parkinsonian features with it. So these will be the most prominent ones. And then less likely you might see other cerebellar related dysfunctions like dysarthria and ataxia. The cerebellar subset is usually one that has more cerebellar symptoms that are prominent more than anything else. But also you'll find that on MRI, there will be atrophy of the middle cerebellar peduncle, which is a sign that this is the cerebellar subset of the MSA. Now, again, this is I find it quite a good summary for the different kinds of atypical Parkinsonian syndromes. But what I want you to know from all of this is the red flags in the history, because this is the most important bit. For PSP, the red flag for someone who's coming with Parkinsonian features is that they tell you they have early postural instability and falls, or they're not able to look down. They're having dysarthria and dysphagia that's very early in the disease, so in the first 2 years, and pseudobulbar effects. This should make you think, is this PSP? Because otherwise, idiopathic Parkinson's disease would not present like that. And on examination, the most prominent sign is the vertical gaze palsy, so they're not able to look down or look up. However, the multiple system atrophy, the presenting symptoms would be urinary frequency or retention, constipation, decreased sweating, syncopes or presyncopal episodes, and tremor, which could be either postural or action if present. and early postural instability and falls. Lastly, the corticobasal degeneration. The most common sign in the history taking is the alien limb syndrome, where their hand moves out of their control and does things by itself. Early dystonia. So dystonia, you're not going to be seeing it in any other Parkinson's syndrome or idiopathic Parkinson. It happens very later in the disease if it will happen. So if it's something that's happening early on in the progress of the disease, then that should make you think, is this corticobasal degeneration? They also have this R3 and dysphagia, as well as tremor. But the thing that stands out always in the history is the alien limb and the early dystonia, which differentiates it from all the other Parkinsonian plus syndromes. Now, obviously, part of our clinical approach is developing differential diagnoses depending on the history and the physical examination findings. So you should have in mind all of these when you're assessing someone for Parkinson's, and try to rule it out so you can narrow down the differential. So importantly, Parkinson's disease could be genetic, could be sporadic. The genetic part, we can actually check if there is a strong family history to suggest so, we can check for it, but that would then prompt us to go down the route of whether we need to check specific genes for that if there is a strong family history. There is also, as I told you, dementia of Lewy bodies, which presents with cognitive impairment and Parkinsonian features, and that would go more with dementia of Lewy bodies than Parkinson's by itself. As we discussed, the atypical Parkinsonism, including MSA, PSP, corticobasal degeneration, and sometimes even frontotemporal dementia, which has an association with PSP as well. So this is something to keep in mind when we assess them. And then you need to be aware of the secondary Parkinsonism causes, such as the drug-induced, like with second-line antipsychotics, which can cause that. So you need to be aware of their drug history and whether that might have caused their symptoms. If there is any tumor, any infection, if they have any vascular element, because there are vascular Parkinsonism. Do they have normal pressure hydrocephalus, which could be evident on MRI as well as doing an LP? And then any trauma, repetitive trauma, could actually induce Parkinsonism. Liver failure is something that we need to also consider, and toxins such as carbon monoxide, manganese, MPTP, and so on. These are things to think, depending on the exposure of the person to different environmental factors, you then could consider these as potential causes. And lastly, there are other neurodegenerative disorders, such as Wilson's disease, which is a very important part to assess for and exclude, especially in patients who are young. And sometimes the neurodegenerative aspect happens before any hepatological progression. So it's important for us to keep that in mind when we're assessing someone with a movement disorder generally. Huntington's disease could actually cause some Parkinsonian features, mainly bradykinesia and rigidity. And spinocerebellar ataxia could sometimes present, specifically type 3, could present with Parkinsonian feature. There is fragile X associated ataxia tremor Parkinsonism, which I'll just go through in slight detail later on. And prion disease or Creutzfeldt-Jakob could present that way as well, and it would be, however, very fast progressing. And then there's dystonia Parkinsonism, which is an important subset in young patients that we need to consider. And Alzheimer's disease could occasionally present with Parkinsonism. So as you can see, there are many, many, many causes and differential diagnoses for Parkinson. So the most important part is to take a comprehensive history when the patient comes, so that you can try to narrow down your differentials and know what to look for when you are investigating. Now, these are for your awareness. If there are specific signs or symptoms in the history or physical exam that would suggest an alternative diagnosis to PD, possibly could be secondary Parkinsonism or Parkinsonian plus, but This is kind of a good summary for that. And it helps you know what to rule out and rule in as you assess. So if you have early speech and gait impairment, this is atypical Parkinsonism, definitely. If they have been exposed to neuroleptics, then this is drug-induced Parkinsonism. If they have an onset prior to the age of 40, then we need to check for a genetic form, and they usually would have a family history. Liver disease, if it's present on clinical assessment or history or blood tests, we need to consider Wilson's disease. And then early hallucinations is a very, very good sign for dementia with Lewy bodies, which not present in normal Parkinson's otherwise. And then we have diplopia, and as I told you, there is a vertical gaze palsy. And if there is eye involvement, generally, you have to think first of PSP. And if there's any poor response to the levodopa, that should make you think this is not idiopathic Parkinson, because they usually respond well to that. A typical Parkinsonian syndromes would not present that way, though. And lastly, as I told you, if in physical examination there is orthostatic hypotension, so the lying standing blood pressure has more than 20 millimeters mercury difference, we need to think of MSA, specifically Parkinson's or Parkinsonism subset. If there's cerebellar signs, then we need to consider MSA cerebellar. If there's impairment of down gaze, then PSP. And if there's a high frequency tremor with a component, a prominent kinetic component, then we need to consider essential tremor. And this just goes through what I just explained to you about the many causes of Parkinson's that we may have. As you can see, the list is exhaustive, and that's why a detailed history and physical examination is the key when you're assessing for movement disorders, and specifically Parkinson's. So having went through all of that, now what do we do to work up these patients and investigate them? The best one is DAT scan, which basically helps us know if there's Parkinson's disease. It's less helpful if we're trying to assess whether it's Parkinsonian plus. It's not as specific, but as you can see, for example, on the left side, this is a normal scan. On the right side, however, as you can see, the red and yellow colors are not there anymore, which means there is less supply there, which usually indicates it's like an inverted comma sign. So this is not present, which indicates there is Parkinson. This also could be helpful if we're trying to differentiate between drug-related Parkinsonism and Parkinson, but not if we're trying to assess for the different subsets of Parkinson. It's not as specific. We can also do a slit lamp exam and serum copper and ceruloplasmin, and that is basically to check for Wilson's disease signs, as well as blood tests. And then we can do an LP and quantify the alpha-synuclein component in the CSF, because this is the main pathology for Parkinson's disease. Now, having worked these patients up, narrowed the differential diagnosis with our detailed history and physical, how do we manage them? So with Parkinson's disease, there is non-pharmacological intervention as well as pharmacological intervention, and these are equally important. The non-pharmacological intervention would have a lot to do with occupational therapy and physical therapy, which should be consistent because that is quite helpful for patients, especially early on. The earlier we do it, the more benefit they will get and the better quality of life they will get on the longer run. And there is then the pharmacological intervention. And we need to assess when we're doing our physical exam and we're taking history, is there any component of functional disability? Because if there is, then levodopa would be the first medication to use. We can also use dopamine agonists, but most neurologists now would start with levodopa. Now, we will assess the patients over the course of few months from starting the therapy and see how they're getting on. If they're not getting the maximal or the optimal response we wanted to see, then we can start them on a combination therapy where you put them on levodopa and dopamine agonists. And sometimes we need to add the COMT inhibitors and the MAO inhibitors that increase the presence of the dopamine. And basically, we keep checking on them every few months and see how they are responding to medication and make the necessary changes. There is apomorphine, which is also used in advanced stages of the disease. And then there is a consideration for surgery or what we call deep brain stimulation in certain subsets of patients. Usually this could be offered for patients up to 75 years of age, but there are many other eligibility criteria that they need to go through and see whether this patient would be someone eligible for it, including comorbidities and their functional status, among many other things. Important to mention that residuline in some studies was found to have a neuroprotective effect on the brain, and it's one of the medications that we use in Parkinson's disease management, not by itself, but in combination. The other part of the treatment that you need to be aware of is sometimes there are people who come to you with then they are young and they're cognitively intact, but they have a very tremor-dominant Parkinson's. In which case, anticholinergics like procyclidine and trihexyphenidyl are actually very helpful in managing the tremor part of it. And it actually helps in the pathology of Parkinson's as well. But this is usually restricted to people who are presenting younger and tremor dominant only because the anticholinergic effect on older people could be quite significant and it can affect the cognition. So we need to be aware of that. And then amantadine is another option, and it does help with patients who have dyskinesia. So it helps manage that without actually worsening their Parkinsonian features. And as we discussed, DBS is another option, but that is usually reserved for patients more in advanced disease, and they haven't responded very well, or we've exhausted all the options for treatment. But there has been recent research about whether this could be introduced earlier in the disease to try to manage these symptoms very early on and maintain a better quality of life early on in the disease. But this is all still under research. And the most important part, which is what I told you in the previous slide, is the multidisciplinary approach. So physiotherapy, occupational therapy, and speech and language therapy is very, very important in these patients because it will help us manage their mobility, manage their environment to help with that, and help them if they're having any component of dysarthria or dysphagia and problems with eating. The input of these teams is extremely important, and their involvement early on is vital so that we can maximize the quality of life for these patients. Neuropsychology is equally important because, as I told you, they could be presenting with depression, anxiety, basically sometimes cognitive impairment, as I told you, and dementia. All of this requires neuropsychology input, so their input is always sought after early in the disease. And lastly, social care, as I told you, because we need to make sure that the environment they're going back to at home is actually suited for their needs. So that usually happens in collaboration with physio and occupational therapy as well. And this is just a scheme to show you how patients progress over time. So as you can see, we have two thresholds, the dyskinesia threshold and the response to medication threshold. And the area in between is what we want optimally to reach for these patients to stay within that only. So as you can see, in early Parkinson's, patients usually would be staying in that for most of the time, and their symptoms would be very, very well controlled. However, as they progress in the disease, and that could be sometimes over years, 5 to 10 years, until they reach the moderate and the advanced courses, you can see that First of all, they're not staying. So if we can see the clinical effect versus the timing after you give the levodopa, as you can see, as we advance in the disease, the time where they are in that between the two lines is not as much. So as you can see, in the early, they can stay in that and up to 8 hours sometimes, but as the disease progresses, it becomes less and less, so 2-3 hours. And that's why then we need to increase the frequency of the medication used to help control that. And if they are not within that line and they are under that line, then they will be in an off period where they're very stiff, very bradykinetic, and not able to move. However, if they are in the dyskinetic threshold or above these two lines, then they will have the abnormal movements, which is equally disabling for these patients. And we explained why that happens. So having to create that balance in the management is very vital, and sometimes it becomes much more difficult as the disease advances, as you can see, because we need to give more frequent doses, which means more levodopa, which means more dyskinesia. So we're decreasing their bradykinesia, but we might be increasing the dyskinesia as a result. The more they advance, as you can see, the timing becomes very short, where they are in that period where they're like functioning just okay. They'll be mostly in either a dyskinetic or off period because of the advancement of the disease. And as I told you, it becomes more widespread, so less likely to respond to medication and more likely to have side effects, unfortunately. With that, the prognosis is different for different subsets. So for Parkinson's, idiopathic Parkinson's, we have the honeymoon period, which is where the motor symptoms respond well to the medications. But then as the disease advances, we'll start seeing motor fluctuations with the medication wearing off. And when we're giving more medications more frequently, we'll have dyskinesia. You'll start seeing these things usually after 5 years of dopamine treatment, sometimes longer, but this is the average. And then as they move to the advanced PD, which is 10 to 15 years after diagnosis, you'll start seeing a very prominent motor fluctuation, as we described in the previous slide. Plus, the non-motor symptoms become more prominent, like orthostatic hypotension, for example, and they become less responsive to the medications and will have more complications. Some of them will tend to develop dementia and more motor instability as the disease progresses. But they still can live up to 20-25 years, with relatively half of that time having their symptoms very well managed. It's usually after that they tend to start developing some symptoms that might be more difficult to control, that decreases their quality of life. However, the Parkinsonian plus syndrome, they have less favorable prognosis. So with MSA, for example, you'll find that they'll have early disability, and that can mainly, it affects their mobility. So you'll find that most of them will become wheelchair bound by 5 years from diagnosis. And the survival is usually from 6 to 10 years due to the complications that occur as part of the pathophysiology of the disease and the complications of the signs and symptoms of the disease, with the immobility, among many other things that can increase the aspiration, pneumonias, and chest infections generally, can increase the risk of thromboses, and so on and so forth. PSP, it's very variable, and it depends. There are many subtypes to PSP, which we're not going to go into, but generally there are subtypes which have more favorable prognosis. But within 3 to 4 years, they will be dependent on carers, and death usually, and this is average, some people will be able to maintain a good quality of life much longer and live longer, but this is just an average of what we have seen from patients with PSP, is that within 6 to 9 years of their symptom onset, death usually ensues due to the reasons I just mentioned. And then corticobasal degeneration usually also will cause death within 6 to 7 years of onset of symptoms, again due to all the symptoms that we discussed, like dysphagia and immobility, which has a lot of implications on the overall health of the patients. And therefore, as you can see, the Parkinsonian plus syndromes are having the least favorable prognosis, unfortunately. So this concludes my Parkinson's part of the presentation. We're gonna move to approach to tremors, but I just wanted to check before we proceed to tremors if there is any questions about Parkinson or Parkinsonian plus syndrome.
There's no questions yet.
Okay, should I proceed then? I'll give it a minute. If there's no questions, because the other two are much less longer than Parkinson. So the Parkinson is the main part. So I'll just give it a minute.
Yep.
Thank you. And obviously, I'm aware I've shared a lot of information with you, so we can share the slides with you if needed, because it has a lot of summarized tables, which I find very helpful when you're studying for these things. So I'm more than happy to share that with you if needed. If there are no further questions, I will move to the approach to tremors. So basically today we are discussing Parkinson's, tremors, and tics. These are the most common movement disorders that you'll see in neurology. And you'll see quite a lot also if you're doing any medical rotations or A&E rotations. So I decided to focus on these three because having rich knowledge in all of these will help you manage things that are very commonly presenting in medicine as well as in A&E. So moving on to tremors. So tremors are basically involuntary, rhythmic, oscillatory movement of a body part. Now, when we want to take history from a patient presenting with tremor, it's very, very important to have a full description because that really helps trying to differentiate which kind of tremor this is, because treatment can be very different. So in history, it's very important for you to ask about which region of the body is affected. When does it happen? So is it at rest? Is it with a certain posture? Is it when they do a specific action? Is it intention tremor? And then when did it start and how did it progress over time? So was it a sudden onset? Was it a gradual onset and very slowly progressive? This is all important information. And is there any limb positions that helps this tremor or actually causes this tremor? Is there any aggravating or relieving factors? So things like we can ask about stress, anxiety, lack of sleep, caffeine, alcohol. There are other involuntary symptoms we also could ask about that are associated with it. Such as, for example, dizziness, lightheadedness, nausea, vomiting. So just ask systemic questions as well about the presentation, and ask if there are any basically things, involuntary movements generally. So movement of other parts of the body when this happens, any vocal involuntary symptoms, for example, and things like that. And check if there in their past medical history there's any either signs and symptoms of thyroid or they're known to have thyroid, any asthma, any psychiatric issues, and any medications they're on. This is important because with thyroid they do become very tremulous, so it's important to check for that. In asthma, with the frequent use of the beta inhalers, that could actually induce tremor as well. And specific medications are known to cause more tremors. So it's always important, and this list could be exhaustive, and that's why it's always important to check the BNF just to see if any of the medications they're on could potentially be causing that. And psychiatric is also important because sometimes there is a psychogenic component to a tremor. So it's always important to see if there is any level of anxiety that the patients are experiencing or depression as well. On physical examination, you need to observe the tremor. So you need to check and make sure that the arms are fully supported and rested, and use distraction techniques and see if that helps the tremor to stop or if it continues anyways. Arms should be extended against gravity to be able to assess properly. And we also need to assess for a kinetic tremor by movement and dystonic intention components. The way we assess for all this is by asking them to do things like a finger to nose test, for them to draw spirals and see how much shaking is there when they're drawing. We ask them to pour water between 2 cups and see if they can actually do that, because if there is a component of tremor, especially with kinesis or intention, you'll find that they will spill most of the water and they won't be able to do it between 2 cups. And then you need to describe the tremor as per your physical examination. So was it only at rest? Was it posture related? Was it action related? Were there any joints involved? What is the frequency of this tremor? And what is the amplitude? So is it something that is very high amplitude and you can see, or is it something quite subtle? How severe is it? Is it always there all the time, for example? Does it impair them from doing their everyday activities? Is there any dystonic component to it? All of these things in history and physical is very, very important because it can lead you to the diagnosis most likely without doing anything else. Obviously, as part of their workup, as we said, we need to check for things like the thyroid function. Wilson's, as I told you previously in the Parkinson's part of the lecture, is that it presents with movement disorders. One of these movement disorders is tremor. So we need to check the LFTs and ceruloplasmin and urine copper excretion and check for physical examination signs by doing the slit lamp test. And then if there is a unilateral symptom component to it, or there are other neurological signs that we can see, it's important to actually do structural imaging. Basically, MRI is quite helpful just to rule out any other causes, to make it just unilateral on that side only. So things like tumors and infections should be excluded. Now, this is a table I quite like as well, just because it summarizes very well all the different types of tremors and what you need to consider when you're assessing. So rest usually is a rest tremor. We see it in Parkinson's disease prominently, and it's usually a pill rolling tremor. And it improves with movement. So once you ask them to move, you'll find that it becomes less prominent. Also drug-induced, you'll find that it causes bilateral symmetrical tremor, and you'll see that it happens with the drug initiation and gets worse as you're taking the drug for a more an extended period of time. And there is a dose-response relationship between the drug and the tremor severity, but it doesn't progress over time. So these two are prominently related to the rest tremors. If the tremor is more task-specific or position-specific, you need to consider one of 3 options. Either it's a dystonic tremor, so it's just a focal tremor in one area only. It's irregular, jerky, and varies with different postures. And we can see them most prominently in arms, hands, feet, and head. Like torticollis and enterocollis, they cause the head tremor, for example, and they're dystonic in nature. You have the orthostatic tremor, which is high frequency and it's low amplitude, and we see it most commonly in legs bilaterally, which causes patients to become unsteady with standing and cramping, and it improves when the patients start to walk. And when you auscultate the gastrocnemius or quad muscles, you hear a helicopter sound. These patients will come to you with mainly unsteadiness. And when you ask them to stand, they will be shaking quite a lot. When they start moving, it becomes less prominent. There are ways to test for it, and there are movement disorder neurophysiology clinics specifically to assess that, to confirm the diagnosis. And then you have, if it's a kinetic tremor, it's usually a cerebellar tremor. And you'll find that there are lesions affecting different parts of the cerebellum. And usually there will be a cerebellar pathology causing this, and this list is also exhaustive. And then there is a postural tremor, and this could be either essential tremor, which we're going to discuss now as this is the most common. There is enhanced physiological tremor, and this is present in almost everyone. It's basically lower amplitude, and it's faster frequency than essential tremor. If there are any high emotions like anxiety, fear, excitement, fatigue, this can make it worse. Caffeine can make it worse if the patient has medical illness like hypoglycemia, fever, thyrotoxicosis, alcohol intake, or alcohol and opiate withdrawal, pheochromocytoma. All of these can cause an enhanced physiological tremor, which is postural in nature. And then there's neuropathic tremor, which occurs in relation to neuropathy. And neuropathy, as you all know, it causes weakness and loss of proprioceptive input. And it occurs with large fiber neuropathies like hereditary neuropathies, or things like Guillain-Barré syndrome or CIDP. So this, as well as essential and physiologic, are usually postural in nature. And lastly, if there is a rest and postural and action component to it, consider one of two, either a psychogenic tremor or Holmes tremor. And psychogenic, as the name implies, it usually has periods of remission and periods where it's more active, and it has to do quite a lot with the psychological status of the patient. And it's usually distractible, and that's what makes it stand out from other types, and you can see it on physical examination. Holmes tremor is unilateral usually, and it's due to either a midbrain or cerebellar injury, and it has a large amplitude and slow frequency, and it is associated with other signs related to the midbrain or the cerebellum. Now, essential tremor, the most important thing you need to know is that it has peak incidences, either less than 40 years old patients or more than 60-year-old patients. And usually there is a positive family history in at least 70% of the cases. So checking for family history is important, because if you have a first-degree relative with essential tremor, you're 5 times more likely of developing an essential tremor. And it's usually a disruption in the olivocerebellar-rubral pathways, and sometimes there are changes in the Purkinje cells or cerebellar cortex and locus coeruleus that could potentially cause that. And there's a diagnostic criteria for it. So it has to be an isolated tremor of bilateral upper limb action tremor, has been going on for 3 years, and it's either with or without tremor in other locations like the head, the voice, the lower limbs. And there are no other neurological signs like ataxia or dystonia or Parkinsonism to indicate that it falls under a different type or a different subset of tremors, as we discussed in the previous slide. Now, the clinical features is usually that it's a kinetic tremor with a postural component in both the upper extremities, and they can have a head or neck tremor. This usually doesn't happen in diseases like Parkinson's, as well as voice and legs. When you check in the physical examination, they might have gait ataxia, impaired tandem walk, and usually the management, if it's non-disabling, so it's not affecting their daily activities significantly, we usually do lifestyle modifications. So we ask them to decrease or stop caffeine intake, or nicotine intake, and try to manage around stress with different outlets to help them manage their stress. And avoid medications that causes tremor. So that will involve just looking at their medication list and see if there's anything they're taking that could be possibly causing this. Now, if they're having it significantly and it's affecting their life, then we usually start off with propranolol and primodone. You need to be aware that propranolol will drop blood pressure, so you need to check with patients as well if they have a known established baseline of low blood pressure, because that could make that worse and basically end up making them more dizzy, which is a side effect that you don't need to have if you can give them another medication. And there are more than one agent that we can give that might not have this effect. So we need to keep that in mind when we're trying to medicate them. There are other options like gabapentin, topiramate, benzodiazepine, and botulinum toxin is something we consider as the last resort if we've tried multiple medications and it hasn't really affected them. Usually surgery like DBS or thalamic focused ultrasound therapy is something we consider only if they have been having this for a very long time. They've tried different lines of medications. They've tried botulinum toxin, but none of that really helped them. This is when they are considered for this. And the focused ultrasound therapy, which is guided by MRI, has been very successful in many patients. And it has been adapted. And again, there's been research about whether this could be used earlier in the course of the disease. And again, this is all still under research. Usually patients might be difficult to treat. 50% of the individuals who receive benefits from medications. Over time, however, the essential tremor would worsen with tendency to spread proximally to the head, neck, and voice. And you need to consider if there are other neurological signs and symptoms like unilateral tremor, leg tremor, rigidity, bradykinesia, gait disturbance. Make sure you rule out Parkinsonism. If there is a sudden onset, weight loading increases the tremor, it's inconsistent in nature, consider psychogenic tremors. If it's isolated head tremor only with abnormal posture, like the head is tilting or moving like this, then it's considered dystonia like torticollis and enterocollis. And lastly, the fragile X ataxia tremor syndrome, which I discussed earlier as one of the differentials. Usually you need to have all of this in order for you to consider it. So neuropathy, cognitive dysfunction, family history of premature ovarian failure. If you have these three, then you need to consider this and do genetic testing for it, because they usually have all these three components. And this concludes the talk about essential tremors and tremors generally that you need to be aware of. The last part of this presentation will be discussing the approach to tics. So I'm just going to stop again for a minute just to see if there are any questions about tremors.
None at the moment.
Okay. Again, I'll just give it like 30 seconds before proceeding forward. The last, it's basically one slide that we're going to go through for tics, and then we should be finishing off. Okay, so the last part of this presentation is going to be discussing tics, and it's fairly common, so I thought it's important for you to be having a bit of information about it. Tics is mainly intermittent, repetitive, non-rhythmic, stereotyped movements and sometimes sounds. The male to female ratio is 3:1, so we see it more in males, and the mean onset is usually early on, so at 4 to 8 years old. You'll find that patients generally will explain what we call an urge before the tic to do it, and they can briefly suppress that feeling, but often it's very uncomfortable for them, and it causes internal tension or urge, and that waxes and wanes over time. and sometimes new and old ticks could intertwine and present in that way. There are precipitating factors that has been common to the subset of patients that have been seen. So things like stress, anger, fatigue, lack of sleep, infections. And we find that it's reduced with concentration, or if they're in their sleeping state, essentially. Now, the tics can be of two types, either simple or complex. And the simple tics, they involve a single or localized group of muscles. So it can be just presenting as blinking, shoulder shrug, sniffing, throat clearing, grunting, barking. Complex, on the other hand, it will be a pattern of movements. So they will clap a certain number of times. They have to do that. Or they touch the chin after coughing, jumping for multiple times, bending, and things like echolalia or palilalia. Echolalia is basically when they repeat what the other person is saying, and they repeat it 2, 3, 4 times sometimes. Palilalia is when they're saying something and they just keep repeating their last part of what they said over and over again. That could be up to 10 times. Tourette disorder or syndrome is one of the most common disorders known for tics, and they usually have multiple motor tics and sometimes more than one vocal tic. And you'll see it in patients less than 18 years of age usually. It's waxing and waning. The duration is usually longer than 1 year. And you need to check that it's not substance-induced or due to a general medical condition to reach that diagnosis. And we manage these patients only when the tics are interfering with their activities of daily living. So it's important to check how much it's impacting their daily life. It's also important to treat the comorbidities associated sometimes. So things like ADHD, OCD, anxiety, depression, sleeping disorder can make this a whole lot worse. So we need to treat these as well if we think that this is mainly contributing to the symptom presentation. Education is equally important. So we need to educate the patient and their family and the school so that they're aware of what Tourette entails and how they can manage around it. We always reassure the patient and their family because this is fairly benign, and if we control the environment and control the other comorbidities, they're more likely to remit from it. Manipulation of the environment is important. Treat and trigger, which could be different in different people, so we need to check what usually triggers it. There is habit reversal training, which also helps them to come out of it. Lastly, medications. You need to consider the risk and the benefit profile based on the tic severity. So we have the first line and the alpha-2 agonist, which things like clonidine, guaifecinidine, clonazepam, and topiramate are things we could try from a medication perspective. The second line would be atypical antipsychotics, risperidone, ziprasidone, and ariprazole. And the third line would be haloperidol, pimozide, and flufenazine. But however, from all what I just explained, the only FDA-approved medication for tics is actually haloperidol, aripiprazole, and pimozide. The rest have been trialed, and some patients had good responses, so they're included as part of the management plan for the medications perspective. And usually with the prognosis for this, it's a rule of thirds. So third will have their tics disappearing, third will improve, and third will persist and continue to have tics over time. But as I told you, it's very important to look at it holistically and try to manage all of these things because that makes it more likely for it to remit and disappear rather than continue over time. So that basically concludes my lecture. This is the references I've used for this presentation. Thank you so much for listening. I know I provided lots of information, but I hope that was useful to you. And I'm more than happy to provide you with the presentation if needed. These are QR codes. If you can kindly give some feedback about the lecture and if there's anything else you would like to be discussed. Thank you so much for listening, and I hope you have a lovely weekend. If you have any further queries or questions about this in general, or you want to ask about anything related to training or academic pathways, I'm more than happy to be contacted by email. This is my email, l.tuleimat@nhs.net. Thank you so much for listening once again, and I hope you have a lovely weekend ahead.
Thank you so much, Dr. Lin, for presenting. We have a few thank you messages, and they said that your talk was very interesting.
Thank you so much. Thank you. I'm really glad that you find it helpful, and I'll make sure that you are provided with the presentation because it has a lot of good tables that summarizes things very well, and I know it's easier for you to read through when it's like this. So I'm more than happy to share it. Thank you so much for listening. Any questions at all? I'll stay for 1 to 2 more minutes just to check if you have any questions, but thank you so much for listening.